Well, it's a pleasure to be here with you. I've been giving a lecture like this all over. I just actually came back for a month in Japan and gave 7 lectures in 28 days. But I've given it at most of the, maybe over the last 7 years, probably between half and 2/3 of American medical schools and our major hospitals. I've given it in Europe as well. So I'm asking myself, why am I doing this? Now, you're a nice group and you were kind enough to invite me, but I have to think about why I'm doing it. And it puts me in mind of a joke, so I'm going to start with a joke just to, since we're a small group, we just sort of lighten our engagement and make us all more friendly and happy, I hope. And it's a story of, the joke is a story of a man who was a great harmonica player. And he was the greatest soloist on the harmonica. And he was invited finally by the New York Philharmonic to play the solo harmonica. And he practiced and he practiced, and he goes to the New York Philharmonic. And you know, the New York Philharmonic is a very sophisticated audience. And in the first 2 or 3 rows, people are actually following the score. Okay? And so he launched into the Bach preludes and played them right through. And at the end, there was a standing ovation. And in the back of the audience, a small voice cried out, "Play it again." To which he said, "I'm just delighted with this response. I will play one of the preludes again." And he did that again, standing ovation. And once again, in the back of the room, the small voice, "Play it again." To which he says, "Ladies and gentlemen, I'm so delighted with your response, but I'm just too exhausted, I can't play it again." And the small voice says, "You'll play it again until you get it right." So that's what I'm trying to do. I'm trying to get it right. So the fact, you know, whenever you hear someone, you want to make sure that they're up to the task. And I've been working, as you heard, in this area for a long time. And my first single-authored book, Patients and Healers in the Context of Culture, was way back in 1979. And my book, The Illness Narratives, which is taught at about half of American medical schools, was 1988. And these other books were more recent, and there are a list of some articles that I've done in the New England Journal of Medicine, and a whole series I did in The Lancet and other places. But today I'm going to talk about the book on your right, which is The Soul of Care. This is the book I'm going to talk about. And I want to begin by saying that this book is both a memoir and the analysis of caregiving. What is caregiving? And it begins right now with a critique of the image in the West we have of medicine. That is the rod of Asclepius, which is a winged staff with a serpent wound around it. And I've always felt that this was an inadequate representation of what medicine is about. Because much closer to what medicine is about is the caduceus of Hermes, or Mercury, which is a winged staff with 2 serpents wound around it, looking at each other and emphasizing the idea of reciprocity. That medicine, at its core, is about the doctor-patient relationship, and that relationship is about reciprocity. Now, I want to draw from my own life. This is a story based in the fact that there's a personal element to this. So this is 1965. I'm a third-year Stanford medical student. That's my wife, Joan Kleinman. This is our wedding day. At Stanford in the 1960s, in 1965, it was said that Katharine Hepburn was a Joan Kleinman lookalike, okay? And Joan was a vibrant woman and a great China scholar. And she brought me into the China field. Here's a picture when I was a resident at the Mass General, and Joan was doing her Chinese studies in the graduate school at Harvard. And this was Joan in midlife, and the two of us in midlife. And Joan in her late 50s, just before the early onset of Alzheimer's disease. So Alzheimer's disease, is a grab bag for a variety of problems that lead to dementia. And we really don't understand the full spectrum of Alzheimer's. But one part that's different than the rest is early onset, which can occur as early as the 30s, and often happens in the late 40s, and in Joan's case, happened in the late 50s. And what's characteristic of this disorder, this kind of Alzheimer's, is that it often starts in different parts of the brain. So Joan's Alzheimer's began not in the midbrain, not in parietal and temporal lobes, nor in frontal lobes, but in her occipital lobe, meaning that it began with blindness, okay? A central blindness, and then became a cognitive deficit, and then a personality change, as dementia is. And this is Joan just at the time that the diagnosis was being made. I hope some of you will get to read the book, and in the book you'll see that because I was at Harvard a long time and had many friends, I had many friends who were senior faculty members and experts in their fields, in ophthalmology, neurology, neuro-ophthalmology, who wanted to help me and make the diagnosis. And they probably made the diagnosis with Joan. This was before PET scans, probably a year and a half earlier than it would have been made at most places. But once having made the diagnosis, they had nothing to say. And this is part of what the book is about. What should they have said that they didn't say? And this is Joan and I. She's sort of in the first 3 or 4 years of her Alzheimer's, which is in our garden. It's a picture actually taken by a great Danish photographer who tried to get the human aspect of our relationship. This photographer, Torben Eskerod, was asked by the Queen of Denmark to take her picture. And he said he would only take it if she did it with her eyes closed so that it could be a preparation for her death mask. So you can see that this was a guy with his own mind. I wanted the picture taken in our study, where I have lots and lots of books. I'm an academic, an intellectual, like you guys, okay? He said, no, the books are up here. We're taking it out in the garden. And so that was this is Joan a year and a half before she dies. She died in 2011. This is 2010. This is Joan on her deathbed, and we were so close in our relationship that when she died, she only had one word, and that was my name, Arthur. We'd been married at that time 46 years. She took care of me for 36 years, and I took care of her for 10 years. And this is her, we have in Cambridge, Massachusetts, if you ever get there, we have a wonderful cemetery called the Mount Auburn Cemetery, which is a National Historical Arboretum. And this is her grave, and it says, beauty, wisdom, goodness, above all love, which was what and you can see that there's plenty of room where my name will go. And this is the other big loss in my life, besides Joan. And it happened after The Soul of Care was written. Soul of Care appeared in 2019. In 2022, my former student and colleague, Paul Farmer, died. And Paul was the icon of global health in the world. In fact, he was widely regarded as the leading medical humanitarian of our era. He died unexpectedly at 60 years of age, 61 years of age. We had a father-son relationship, and no child should die before the parent. And so this was a very, very difficult death for me and for many others. And unlike Joan's death, which was a personal death with individual mourning, this was public mourning of hundreds of thousands, possibly millions of people around the world. And this is Paul in the University of Global Health Equity in Butaro, Rwanda. He was famous for his work in Haiti and in West Africa. And we used to teach a course called Who Lives, Who Dies, Who Cares? An Introduction to Global Health. And this was the two of us. Now, I didn't take care of Paul because he died suddenly, but I experienced the effects so that I cared for memories, something I'm going to talk about briefly. So let's define caregiving, which is we take it for granted it's what we do as doctors, or if there are nurses in the room, nurses, or we do it in families. In fact, most of care is given in families around the world. So care can be defined ethnographically. Ethnography is what an anthropologist does. It's a description of social context, basically. So care is both the individual and the collective human practice of caregiving, protecting, practical support, solidarity, including physical, emotional, interpersonal, and moral assistance. It's necessarily reciprocally linked to the process of care receiving. And reciprocity is its great model, gift exchange, and I'll get to that in a bit. But it's very important in the care of patients with neurodegenerative diseases, particularly dementia. Often the care receiver, the patient, is lost. And if you see the doctor-patient relationship in dementia, when a patient with dementia comes into the office and is speaking to a neurologist or a psychiatrist or primary care doc, often the doc is speaking to the family member, not to the patient, as if the patient were not there. So it's important to recognize the importance of the centrality of care receiving. Okay? And also to emphasize that practices of care are biosocial. They're biosocial. They're biological and they're social. And that biology and those social processes interact in very substantial ways, for which we have more than 50 years of very good evidence. And there are levels of caregiving. There's humanitarian assistance, as I just mentioned, which is caregiving at the collective level. There's professional caregiving, which is usually modeled as individual caregivers and receivers. There's self-care, which in our times has become an enormous industry. There's family and network caregiving, which is hugely important. And there's folk and religious healing, which are also important. And we can think of the essence of caregiving as built on a number of things. One is relationships, the quality of relationships. First of all, the quality of relationships in a family. Over the course of being a clinician for half a century, I've taken care of many people, as I'm sure many of the doctors in this audience have. And my sense of that, and also my sense of reading the literature and my own research, is that the quality of the relationship has a lot to do with the quality of caregiving. Second is presence. Caregiving is about presence. Presence of the family caregiver, presence of the professional caregiver, or absence of presence. And what's happened as medicine has become more bureaucratized as the pressure, the compression of time has become greater, is that presence frequently drops out. And what should be the deepest kind of relationship becomes simply a matter of just getting in and getting out. That's not really what caregiving should be about, but it's often what happens. But think about presence. Presence is very interesting. I'm a devotee of a former Montreal singer named Leonard Cohen. And Leonard Cohen, in his famous anthem called Hallelujah, talks about presence and says that presence is drawn out of us. It isn't just from us, it's drawn out of us, if you remember the words of Hallelujah. And that idea, I think, is very central to the way I'm presenting the giving of care and the receiving of care. No presence without the quality of the relationship which draws us out, draws it from us. Care is about rituals and habits. Just think of the way that we ceremonially order the doctor-patient relationship. Think of a pelvic exam. Could a pelvic exam be done professionally without a formal ritualized order that takes the sexuality out of it and makes it a act of caregiving as opposed to exploitation of a body? Rituals and habits are also critical to care in family settings. So, for example, I took care of Joan for 10 years. The last 9 months were impossible for me because I just couldn't lift her when she became really totally unable to move. I couldn't lift her effectively from bed to bath, etc. And so she went into a nursing home for 9 months, which I'll talk about. But the only way I did it for 10 years, and this is true of all family caregivers that I've spoken to and studied and read about, this a huge literature on family care. Now, it's a huge industry, actually, of writing, is that people ritualize the day, just like I did. Woke up in the morning, woke Joan up, took her to the bathroom, handed her the toilet paper, sometimes had to wipe her bottom myself, got her dressed, worked out with her to the extent that she could work out, took her to the shower, helped shower her, got her dressed for the day, brought her to the kitchen, organized our meal in a certain way so that I could feed her so she didn't choke on her food and have aspiration pneumonia, and had a way of continuing from that point on for the day when I took care of her, or when our home health aide was available. So what made family care possible for me was that I could afford a home health aide. In Canada, you have a national health system. We don't in the United States. But in places like Japan and Scandinavia, and Germany and Holland, where there are national health systems, there is long-term care insurance that pays for home health aide. I paid for the home health aide myself because we don't get a home health aide in the United States, paid for by insurance. Very few Americans have long-term care insurance, can afford it. Just to continue in that for a second, to give you a sense of the finances of this, the 9 months that Joan was in a nursing home, her last 9 months, I had long-term care insurance for her. That paid $50,000 toward her last 9 months. I paid $150,000. That 9 months in that nursing home cost $200,000. And that's a wonderful nursing home, Newbridge on the Charles and Dedham, Massachusetts. So rituals also are associated with habits, the way that we embody the ritual and how we do things. We know that from the way we're trained in medicine. We're trained in medicine in such a way to make it feasible for us to do the things that we do. And there have been terrific studies of this in the training of surgeons. There's a great book, Forgive and Remember, on the training of surgeons and how they embody habits. The same thing with internists, with psychiatrists, and the like. And this embodiment of habits, again, makes it possible for us to get through a day without it being chaotic and disruptive and making it psychologically impossible for us to get on. Enduring. This is a big deal with me because I believe, quite honestly, that the idea of resilience is a non-starter. Okay? Resilience is a Hollywood term, picked up by psychologists, but really is a Hollywood term. And what it means basically is that you're a rubber band, you can be stretched, and you come back to your original shape. No one taking care of sick people over a long period of time can be resilient. It's as if that rubber band were placed out of doors in the sun for 3 or 4 days. You do that, show it to yourself. That rubber band becomes brittle. When you stretch it, it breaks, okay? All of us who take care of someone in our lives in the family chronically are somewhat broken. But I want to make the case that that's true of us as doctors as well. And that rather than being a negative thing that we should be afraid of, it's a good thing. It's just as Leonard Cohen said, it's the break that lets the light in. Okay? So enduring, how do we endure? I learned this from being a China scholar. I've done my research in China for a long period of time. And what I was taught by Chinese over that period of time came from an ancient wisdom in Chinese society, in a society that had multiple famines, epidemics, chaotic politics, easy and quick deaths for many people. And the wisdom was, you've got to endure. You keep going and you endure. And the way that that has been said to be by hundreds of family members with patients with dementia or other neurodegenerative diseases is that there was the work to do, taking care. I never made a decision. It was there to do. I did it, and I endured. I kept going. I just kept going. Actually, let me spend a moment on that for a little further. There's a very interesting book that was written by a writer for The New Yorker, really excellent writer, E.S. Goldman, called The Caregiver. And I had the privilege of writing the preface to his book. And so when Goldman gave a talk at a bookstore in Boston, I was asked to accompany him. He, at that time, was 93 years of age. He had had the same experience I would have later, taking care of a wife who had Alzheimer's. In his case, not early onset, but Alzheimer's associated with the elderly period. He gave this wonderful talk. He was holding onto if you can picture it, holding onto a walker. There was a little spittle in his mouth from a slight stroke he had had. And he said, "Are there any questions?" And a young woman raised her hand, and he said, "Yes." And she said, "I don't get it. I just don't get it. It was so hard what you did. Why did you do it?" And Goldman, who had been did not have any cognitive deficit, was clearly very puzzled. And he said, "I'm sorry, could you repeat the question? I just don't understand the question." And she said, "Yeah, why did you do it? It was so hard to do, why did you do it?" And he said, "Well, it was there to do, it had to be done." I've heard that hundreds of times from people. And just think about that for a second, because it's also part of the medical profession. It's there to do, you're doing it. Okay? You're in it. It's when you're in it and doing the care, doing the diagnosis, doing the treatment, your clinical judgment, that is the caregiving. There's a thing called caring for memories. Actually, I'm writing a book about that right now because I think this is incredibly important. And the argument is that we are mostly memories. We're filled with experiences. The idea of the conscious and unconscious is not nearly as useful as thinking about the fact that we're filled with experiences, some of which get formulated, some of which don't. And caring for memories is about working with formulated experiences and formulating experiences that were previously unformulated. And that caregiving is what bereavement is about. That caring of memories is the centrality of bereavement, as fundamental as the sadness and the yearning in the experience of bereavement. So caring for memories is also the case with practitioners, that they don't talk about it. That all of us as physicians keep memories of certain patients we've had who have an iconic effect on the way we think about things, a fundamental effect. I remember when I was a resident at the Mass General and took care of a young woman who I felt I really got to know. She was suffering from an addiction. She was addicted to barbiturates, and I was slowly taking her off the barbiturates. But in order to taper her off, I had to prescribe them. And unbeknownst to me, she saved her barbiturates, took them all at once, and killed herself. Okay? And it was a lesson to me, a great lesson in taking care of patients about the danger of suicide. And then I'm going to talk about human developmental process. Let me get to that in a second, and also barriers of care. So the core tasks of caregiving are these. The first one is acknowledgement and affirmation. That is the basic ethical response in care. It's the acknowledgement and affirmation of the person's right to care and your being with them with the care. That affirmation occurs when you look a person in the eye and say, what's wrong, how can I be of help, etc. That affirmation today is much harder because of the electronic health record. Okay? As my colleague Atul Gawande has pointed out, the only good thing about the electronic health record is that it improves billing. Okay? Otherwise, it has failed in almost every other dimension that it was originally intended for. But it does have this effect. It means that the practitioner, the physician, often has her back to the patient when the patient comes in the room. Just think about, how do you acknowledge and affirm someone when your back is to the patient? Okay? Accompaniment. This was Paul Farmer's great term for the movement of saying, I'm with you in this, and I'll be with you in the care of this. He took this from his Catholic background and the idea of liberation theology, accompaniment with the poor. He took it literally in his life also as the corporal task of mercy. His idea was that accompaniment was critical to what medicine was about. Paul was an infectious disease doctor. He worked with TB, AIDS, Ebola. He played a major role in the most recent Ebola epidemics of 5 years ago, and in West Africa, and cholera. And his idea of accompaniment was giving that sense, along with medication, that I'm with you in this. I'm going to go with you. I'm going to follow through. I'm not just dropping out at this point. Practical assistance and the actual work of care, which family members do. Nurses used to do, but nurses don't do this anymore. It's done by nursing assistants in the hospital. Nurses are filling out forms most of the time nowadays, unfortunately. But feeding, bathing, ambulating, toileting, protecting. Protecting is really important because if you think about it, this is the care that mothers and fathers and even sibs give to little children, okay? Protection is very important. And protection is also important in care of the elderly, care of older adults. That's why control is an issue along with care. We like to distinguish usually care and control and see control somehow as something we want to get rid of, but you can't get rid of it in care. Because in fact, one of the key, if anyone speaks Chinese here, one of the key words in Chinese for care is guan, guan li, guan. Guan means both care and control. Emotional support is a crucial aspect of caregiving. A former student of mine, Nicholas Christakis, who's at Yale, wrote a terrific book on prognosis, in which he showed that physicians almost automatically try to show that the glass is half full rather than half empty, with the idea that they're giving emotional support when prognosticating. Moral solidarity and responsibility. I gave this talk, the same talk you're hearing, in Stockholm, Sweden, and the Lutheran bishop raised his hand and said, yeah, I know exactly what you mean by moral solidarity. Sometimes I visit families with patients who've had a stroke or comatose, and they don't know that I'm there, but my presence is meant to be morally significant for the family. I talked about presence and enduring. Now, care and caregiving as human development. So care really, when we think of the term care, it's not just giving care in terms of caregiving. It's beginning to worry, or being troubled by something. It's being concerned. It's being serious. It's being the term that we usually use in academia, serious. That's a serious student. It means someone who's taking care, who's really into it. We have lots of studies that show that childhood socialization is different by gender. Women all over the world are the caregivers, family caregivers. Part of this is probably biological, but a large part of it is social, the way you're socialized. I was socialized in a time that's gone forever, the 1940s and early 1950s. Okay? In that time, in America, boys were socialized to be wantonly careless, girls to be careful. The very attention and worrying about things, the concern, etc., was built into the idea that you would be a caregiver at some stage. Now, we're hoping in our age that with your generation, I'm looking at the medical students in the room, that there'll be a more mature masculinity coming out that'll balance feminine commitments, and that women, of course, are into the workforce, into their own lives, so in a sense, who's home to give the care amongst the elderly? And men have failed, in my view, to take this responsibility as seriously as they need to, except when they're paid. So I often go to Sydney, Australia, where I have close friends, and if you're in Sydney, Australia, and you go to one of their wonderful coffee shops, and if you're in Australia, you drink the coffee, okay? You'll see men with strollers as often as you'll see women. And that is because men are paid for doing that, for doing the care. So gender looms large. Now, there are challenges for caregiving. For families, in most societies, long-term care funding is the big one. Okay? If you don't have the finances for family care, you cannot do family care. I mentioned increasing numbers of people entering the workforce, so no one at home to do the care in families. There's an equivalent in professional care, as nurses and doctors get taken up in much more technical tasks. Who does the care? The challenge of values today. I don't think I need to make this point given the current president of the United States, who radiates a set of values that are the antithesis to care. Okay? But there are other things that contribute to this as well, in my view, which is the radical individualism of our time, the sense of an absence of responsibility for others. If you don't have that, it's very hard to see how you support care. Stigmatized conditions often means that the stigma is transmitted as sort of courtesy stigma to the caregivers and discourages caregiving. And then there are knowledge and communication gaps. Let me tell you what I mean by that. If you're a family member and you have taken care of a family member with diabetes, and they have maturity onset diabetes, and they're on one of the drugs commonly used today for maturity onset diabetes, and you've done it for 4 or 5 years, why do you have to go through a doctor or a pharmacist to get a refill of a prescription? Most of long-term care, most of care, that kind of care I'm talking about, is waiting. It takes up time. So one of the things that we need to do in the future is assure that family members have the knowledge for medications that are used routinely in the family, and let them prescribe themselves, let them refill. Professional limitations. One is limited time. So commonly told by my colleagues in medicine that we just don't have the time. But actually, time studies done by sociologists show that we do have the time. We don't use the time. Time studies of residents in American hospitals show that residents, 1/3 of the time that they put in front of the screen on their computers could be devoted fully to caregiving of patients, at least going into the patient's room and speaking to them. They don't do it. So the limitation on time is in part a perception issue and a culture of the way that we're training you in medicine. I mentioned barriers of electronic technology. I'm a big fan of technology. I believe in technology. But if you look carefully at technologies in medicine, they often worsen caregiving. There's no reason for that to happen. We should make sure there should be a kind of a effect on care impact statement, similar to the impact statements we have for environmental policies, et cetera. But we don't have that. And there are weakened incentives for quality care. I'll get onto this in a little bit. Now, measuring care. We have no direct measures of care. What do we do? Why is it that we can say a hospital claim, we give high quality care? What do? It's a sleight of hand, but a powerful one. We take institutional efficiency and we substitute it for care. Institutional efficiency is X number of patients with Y condition moving through a healthcare system with U cost and Z outcome. That has nothing to do with care. That is a measure of efficiency. I'm going to make the claim in this lecture that as important as efficiency is, it is sometimes the enemy of care. Okay? We've sold out on bureaucratic efficiency. And the other thing we've sold out on, of course, is profit. So to measure care, we need to measure time spent together, quality of interpersonal relationship, quality of communication, including listening, explaining. Let me ask the medical students in the audience, do you have a course at whatever medical school you're at on how to explain to patients, how to explain a diagnosis or treatment? If you do, it's a radical difference from what most medical students around the world have. Okay? And yet this is one of the most important things you will do. And if you see studies of patient satisfaction, they almost all turn on this particular thing, the quality of explaining, listening, and responding to questions. The quality of the history taking and the physical exam. We were lamenting at dinner the diminishment of the physical exam. So, of course, we have technology that's better than the stethoscope, that's better than taking the pulse, better than figuring out clinically what the heart, what a heart murmur is, et cetera, and what significance it has in terms of ejection fractions and the like. All those things now we have technology for. And yet the physical exam is still crucial. Why is it crucial? Because it's the time you lay on hands. It's the closest you get to a patient. It's the contact with the patient, which is central to the physical exam. No physical exam, limited contact with patients. Quality of clinical judgment. We simply do not measure clinical judgment. It's astonishing because in the law, in many other fields, architecture, the equivalent of clinical judgment is constantly measured. We don't do it. Now, I believe that AI, and I'll speak about this tomorrow, can help us with all these measurements. I believe that AI can never substitute for a caregiver and must never substitute for a human caregiver. But AI can help with all these measurements, and in the future, well, it will be a future that I won't see, given my age, but you guys will see it. That future, you will see a measurement of care come in. Now, there are three paradoxes in terms of where is caregiving in medicine and healthcare today, and I want to go through these three. First paradox is caregiving in medicine. Medicine traditionally defines caregiving as central to the practice of the doctor. Over time, caregiving has become much less central to medical practice. The paradox is we don't spend sufficient time or money on caregiving, either in practice or in the curriculum, yet we still consider it central to what medicine does. That's a paradox. Paradox 2, medical education. We have 8 major studies in the United States that show that medical students are both more interested and better at the practical, emotional, and moral aspects of caregiving when they first enter medical school than when they graduate. I think if you're a medical educator, I've spent my life as a medical educator, this is the most devastating finding you can imagine. It means that you guys who are medical students are going to experience some toxicity as you acquire a very fundamental understanding of science and technology. You're going to be disabled in the human aspects of care. Why does that happen? How does it happen? How do you get socialized into that? That's what happens, at least in American medical schools. I've made a Swiftian proposal. You remember Jonathan Swift, Dean Swift, who wrote Gulliver's Travels. Dean Swift was, at the end of the 18th, beginning of the 19th century, was appalled by the Irish famine, which, of course, helped build Canada and the United States. But nonetheless, he was appalled by the deaths in the Irish famine. And so he wrote a famous work called A Modest Proposal in order to generate outrage. He said, let's eat the children. Let's eat the children. Because if we eat the children, we don't have to slowly watch them die of starvation, and we ourselves will be able to keep ourselves alive. And of course, there was outrage to that. And so he said, okay, take that outrage now, don't have it at me, aim at the famine and do something about the famine. So I've suggested the same thing at a lot of American medical schools. Why don't we just say doctors don't have to do any caregiving? And we can say that physicians basically are the equivalent of very high-level car mechanics, okay? But very high level, okay? Car mechanics. And we should pay them accordingly, et cetera. You don't expect, I don't know, I'm sure most of you own cars, I do. You don't expect, the mechanic taking care of your car to say, hey, this is really a nice car, put his hand on it and just rub it nicely and say, you ever look at the interior? This is really a lovely car. And you could take better care of this car, We don't expect them to give care. So should we expect a doctor, if everything I've told you is right, maybe we should just exonerate doctors. Don't give the care. Care will be given by nurses or nursing assistants or social workers or family members. It doesn't have to be doctors. And when I propose this in settings like this in medical schools, hands shoot up immediately. And they say, Professor Kleinman, we invited you here to inspire us about care. How can you challenge us by saying we should give up care? And it goes on. And finally I stop it and say, great. The same as the outrage toward Swift. Turn it away from me, turn it toward care. Put more money into training of care. You take it seriously, examine for caregiving skills, and et cetera. No medical educator or head of a clinical department I have spoken to is willing to consider removing caregiving from its iconic place in medicine. That's paradox 2. And paradox 3, just to make a long story short, is simply that, as I've mentioned earlier, so many of the technologies that we've introduced actually worsen care. They shouldn't. So what can be done? First, on the family side, we can provide long-term care insurance. I think that in terms of dementia, of neurodegenerative disease, of chronic diseases generally, this is crucial, providing long-term care insurance. And I think that I'll just leave it at that. We can compensate for family care, both for care of children and care of the elderly. All this is free care. If in my country, if 10% of American men and women and men, stop giving care for the elderly, 10% stopped, it would overwhelm every institution in America. Nursing homes, hospitals, clinics, community services, they would all be overwhelmed. Hence, this is crucial care. The society should be compensated. We can improve the cognitive and social supports and appropriate technologies, and I believe that this is a very important area where AI and VR can be useful. I'll just give you an example of something that I'm working with in my research, and that comes from the work of a colleague of mine, Jill Bennett, in Australia, who's developed AI and VR for dementia patients when they are agitated. It's a reminiscential therapy in which built into the AI and VR are film, pictures from the past of individuals at times that they were relaxed and calm. When they become agitated, and agitation is central to the experience of dementia, instead of using drugs which knock them out and produce zombies, you just put on the VR with the AI and you watch the agitation melt away as people get into a safe space. Professionally, we can strengthen the moral training of professional caregivers. That is, caring is central to what the doctor does. Therefore, we must reward it and we must examine for it and show its seriousness, and we must do everything to support it. Improve the training in core caregiving skills, the ones I mentioned earlier. Incentivize caregiving in daily practice. Right now, we de-incentivize it. Complement the economic, look, let me just say this another way because it's part of my message. My generation has given away the language of care. We inherited a clinical language of care, which, as health policy developed over the last 50 years, we gave away that clinical language and accepted entirely an economic language. Economics is not the language of care. As AI is algorithm, not human brain, algorithm, even if you have an AI companion, not a person, not a brain, an algorithm. So in health policy, we've given up the human language of care and allowed an economic language to be that language. Cost efficiency, cost efficacy. Okay. We've got to complement that language with the language of care. And I'll leave the other one aside for the time being. To revitalize care in medicine and healthcare, all first-year students, in my view, should have the experience that many students in Holland and Germany have. And about half of the medical schools in those two countries, and a few in Scandinavia, the week before or the 10 days before the first year of medical school begins, students are sent out and put in with families that have a seriously disabled or seriously ill member. And since they don't know anything, they haven't started medical school, all they're asked to do is to participate in the family care. I was a Cleveringa professor at the University of Leiden some years ago. And I gave a lecture like this, and in the audience was the entire faculty of that university, half of whom had graduated from their training program that did exactly this. They told me, to a person, they told me, this was the single most important thing in medical school they experienced. Can you imagine that? It happened before medical school. It was the single most important thing because it showed them what illness experience was and what treatment was about and how care is given. So we should do that with first-year students. We should have students and residents at least once or twice write a mini ethnography, a description of the patient and their family, just to make clear how important context is. We should emphasize collaborative learning and teamwork with nurses, physical therapists, home health aides, so that we diminish the kind of autarky, the autocratic structure of care in which physicians are at an elevated level. We have to bring the physician down into the team. We've got to give longitudinal clinical experience in home health care. And we have to systematically evaluate caregiving skills of students. Now, I don't know how things work in Canada. In America, it's very difficult to flunk out of a medical school. Nonetheless, we do flunk some people because they don't pass their biochemistry exam several times, okay? But shouldn't we flunk someone out who doesn't pass their clinical exam several times, who can't do the clinical care that I just talked about? And shouldn't admissions committees to medical school have this as one of the assessing factors for them? What's the quality of the student's ability to give care? Okay. That's what I'm talking about. And we should overall affirm the centrality of caregiving and put more time in the curriculum and training. This means devoting greater resources, financial and personal, building caregiving process measures, evaluating caregiving skills, developing and funding research on process and outcomes of caregiving. It means developing a caregiving impact statement similar to environmental impact to assess impact of technology and financing on caregiving. We need to incentivize caregiving, educate in the core skills, reform computer technology to reduce the amount of time physicians spend in frustrating computer work. One great example is AI-based medical scribes, for example. Go beyond bureaucratic protocols. Emphasize, and this is really important, and you guys are all of us have taken courses must attend to medical ethics. We do medical ethics wrong, in my view. We emphasize only abstract principles, okay? Those are important. Justice, beneficence, non-maleficence, etc. They're all important. Autonomy, all important. But we don't emphasize enough the moral cultivation of the physician, the training of the physician, the moral education of the physician. That's your own personal training. I'm going to skip this as well. So what I'm trying to do, trying to get it right? What I'm really trying to do is to build a moral movement for care, which is in medicine, but has to go way beyond medicine. Because the great power here is the ordinary woman and man in society. Getting them involved in a moral movement for care is critical. That requires recognizing the anti-care biases of our time, advocacy and community work to generate a moral movement, legal and policy interventions to support family care and social care, changes in medical education, changes in the healthcare system, responding to burnout as if it is classical Marxist alienation of the worker from the product of her work, okay? And the moral cultivation of the physician. Aristotle said, moral excellence comes about as a result of habit. We become just by doing just acts, temperate by doing temperate acts, brave by doing brave acts. And we become caring and caregivers by doing acts of care and caregiving. My great former late student, Paul Farmer, said that accompaniment was the ethical engagement of the physician. For me, said Farmer, an area of moral clarity is you're in front of someone who's suffering and you have the tools at your disposal to alleviate that suffering or even eradicate it, and you act. Oops, someone else's slides. Let's go back. How do we get that off?
Unrelated.
But it's a nice place to end, though, you know.
Sorry.
It wasn't my end, but.